Very good. Thank you so much for this opportunity to be here and speaking with you about our work at the North Carolina Department of Health and Human Services. My name is Ben Money. I'm Deputy Secretary for Health Services. And I wanted to speak with you tonight about our efforts at slowing the spread of COVID-19 in the Black community. And I've got a few slides to kick off our discussion tonight. Hopefully you all can see them. One of the things that we've done at DHHS is really focus on those populations that have been disproportionately impacted by COVID-19. And one of the things we found is that folks that have health disparities, economic disparities, have been marginalized. And that's a term that essentially says that they've been pushed to the side and have been suffering from economic and social deprivation for years, have been the hardest hit from COVID-19. And we've defined that as a historically marginalized population. We're speaking in North Carolina specifically of African Americans, of Native Americans, and Hispanic Latinx population. And so we put a concerted effort towards our work at alleviating the disparities within historically marginalized populations, particularly as it pertains to COVID-19. So one of the things that we saw is that when COVID arrived, people were asked to stay home. But there were a lot of folks that couldn't stay home. They were deemed essential workers needed by society to keep grocery stores stocked, to keep gas stations running, to keep food production underway, to keep hospitals and other institutions functioning. And what we found and what we already knew was that these workers tended to be Black, Hispanic, Latinx. They often were represented in frontline, low-wage positions within these sectors. And while many people had the opportunity to shelter in place, to work at home, to telecommute, one of the things that we found is that less than 1 in 5 Black workers and roughly 1 in 6 Hispanic workers were actually able to do that. So most people that we saw in these frontline positions were people of color. And so what are some of these positions that I'm talking about? Home health aides, personal care aides, as I said, folks that are working in food processing, food delivery workers, housekeeping, domestic workers, childcare workers, sanitation workers. These are essential workers. And these workers are every day putting themselves in a position where they're coming in contact with more and more people, increasing their risk of exposure. Often they're working second jobs. They're often living in multi-generational households. They're relying on public transportation or shared rides. They often have less health insurance. They don't have jobs that will pay sick leave. And often they're in a position where just missing one paycheck can mean the difference between staying in place or being evicted. So we also know that there are health conditions that increase the risk of severe illness from COVID. So if you contract COVID because of your workplace exposure that forces you to be in contact with multiple people multiple times a day over multiple periods of time, and if you have a severe illness, then it not only increases your risk of contracting COVID, but also for that COVID infection to actually lead to a more severe case of illness and potentially death. And some of these things here are chronic kidney disease, obesity, heart conditions, sickle cell disease, type 2 diabetes, asthma, hypertension. These conditions tend to be disproportionately higher in African Americans and people of Latinx descent in North Carolina as well as around the country. What we're seeing in North Carolina is not different from what we're seeing in other states. It's just COVID really has shown a light on these disparities. So what we did at DHHS was developed a strategy by pulling together entities from within our department, from within state government, as well as partners across the state from different agencies to really look at what we could do to protect historically marginalized populations from COVID infections, from complications that they are infected, as well as transmission. And we built our efforts around our 4 pillars of COVID response, which is prevention, testing, contact tracing, wraparound services. And then we actually added 2 more, behavioral health and making sure that community organizations had access to state contracts and resources. So as I said before, not only across departmental, cross agency representation, but also outside of state government, healthcare provider organizations, community-based organizations, as well as advocacy organizations involved in our work. We have about 70 individuals that come together on a weekly basis we break out into teams and work on these various issues. As I said before, our focus is on those 6 areas. And we have aligned ourselves around not just the COVID response for today, but also thinking forward about what the needs are going to be in the future. So our first work stream is around prevention. One of the key issues is information, misinformation, and lack of trust, and also making sure that the information we provide is culturally and linguistically appropriate. We know that people that live in close quarters or rely on shared transportation have challenges of physical distancing as well as hand washing. And we want to make sure that when a vaccine is available, that people will understand the need for the vaccine, understand the risk and the benefits, as well as participate in getting the vaccine. We're also very engaged in supporting clinical trials and making sure that there's enough diversity in those clinical trials. So one of the things that you've probably seen is the 3Ws campaign. We've also done this campaign in Spanish as well as the 3Ms. It's all about wearing a face covering, that social physical distancing, waiting 6 feet apart, and washing your hands. There it is in Spanish. It's the 3Ms. And one of the things that we learned through our efforts in engaging the Hispanic Latinx community is that W's don't really resonate in Spanish. And so we developed this campaign particularly for that community. We also have done prevention messages around whatever your reason, wear a face mask. We understand that there's a lot of resistance to people wearing face coverings, and it really shouldn't be. We're learning more and more about the science of utilizing a face covering. In fact, if you just go back to 1918 and the flu, the great Spanish flu pandemic that occurred then, you see people in those old pictures from 100 years ago wearing face coverings. When we had a shortage of personal protective equipment, the early part of the pandemic, we were really, in a way, discouraging people because the science wasn't clear about wearing a face covering. Now we're all in on making sure that people are wearing face coverings, and not just to protect the other person, but we're learning now it's somewhat self-protective in terms of wearing face masks. Oops, I didn't want to start that. The other thing we've done is created guidance for a lot of different settings. You can go to our website and see it for school settings, for occupational industrial settings, for settings that include sports and other activities. But we also have guidance that we've recently developed for the holidays as well as for religious and spiritual gatherings. And I'll talk a little bit about that later. The other thing that we've done is work with the governor and governor's team on executive orders that have essentially created restrictions to protect the public from the transmission of COVID-19. And you know that we've got these 3 phases that we're in. We're currently in phase 3. And you'll also remember that earlier in the week, the governor stepped back the indoor limitations to no more than 10 people indoors, simply because we're seeing a rise in the virus. Right now, we've crossed over the 300 case threshold. We also crossed over 4,000 deaths. We've had in recent days 3,000 individuals that were newly diagnosed cases of COVID. So COVID is really growing in this state. We've got to do everything we can to restrict the transmission of the virus. Sorry, my mouse keeps moving here. The other thing that we've done, and I mentioned this a little bit earlier, is once we identified the shortage of personal protective equipment, we started purchasing it from all over the world. And we were one of the most successful states in getting things like face coverings, N95 masks, gloves, gowns, as well as sanitizer, hand sanitizer. And we've been putting those materials out to the public, utilizing our organizational partners across the state to distribute those to communities, particularly to agricultural workers, to workers that are in childcare settings, and making sure that our healthcare providers have sufficient resources as they care for patients. We also were very much engaged in developing a toolkit for faith leaders. And that toolkit includes guidance on worship. And within that guidance, we really focus on just some key messages, which really says our recommendation is, as much as possible, to hold virtual services, and that's the safest way. And really across the state, churches complied with that, particularly in the early phases of the pandemic. And also recognizing that there are many vulnerable people within congregations and doing everything possible to protect them. And then looking at plans, if you are looking at gathering in person, to do it in a safe way, to have a virtual meeting with members to go over the necessary safety practices and any changes that are going to be in place for your service, and making sure that each person participating in that service knows their responsibility, and also still having virtual services available so that high-risk members of the congregation can participate, even though they may not be there in person. As much as possible, conduct a worship service inside. If you do plan to worship indoors, limit the occupancy to 30% of the fire capacity or less than 100 people. Also ensure that there's sufficient social distancing, at least 6 feet of separation between groups that are not of the same household. So households can be together, but people that don't live in the same household, even if they're not family members, should be, even if they are family members but not in the same household, should be 6 feet apart or more. So households can be together, separating those other groups. And then again, wearing face coverings, and it's important to recognize that face covering needs to be over the nose and the mouth at all times. And then have folks at the door when people arrive to hand out face coverings if people forget them. You can also do screenings at the door for symptoms, temperature checks, posting signs to remind people of social distancing, even designate places on the pews or the seating where you've got 6 feet apart, or you can group for families. And also consider limiting seating to like alternate rows. One thing to note is that singing can actually spread the respiratory vapor particles further than 6 feet. So really, we're really discouraging singing, choir singing, unless there's some real clear separation in place that doesn't prevent that viral spread, or I should say that prevents that viral spread. Making sure that people are 6 feet apart. And then also avoiding physical contact. I know it's such a tradition, in many faith communities to hug and to greet people warmly. But right now, that actually is a great risk for transmitting the virus. Let's see. And then having clearly designated entry and exit points so people aren't passing each other, going in and out. So one clearly defined way in and a separate way out. And also possible staging entry and exit times. As much as possible, opening up windows if you are indoors to let outside air in, have circulation. And also consider some of the other group activities, consider having them virtually. So you're, again, minimizing that risk of transmission. One of the things that we're finding is that there's a great deal of transmission in church settings, in settings of small group gatherings, and particularly in rural areas. We just put out a report today about the growing number of cases in North Carolina in rural areas. So it's very concerning to us. And church and religious gatherings are tending to be some of the highest areas where spread is actually occurring. Making sure that you've got a routine for cleaning in place, that there's hand sanitizers and hand washing stations, using any food to have it prepackaged, avoid having buffets, avoid serving from common dishes. And then making sure that you've got plenty of hand washing materials on hand, plenty of paper towels, that, there's only like one family in a restroom at a time. You're not crowding the restroom with a number of people that, again, don't live with each other. And making sure that you disinfect things as frequently as possible. Preventing surface contact, like avoiding handing out things that get touched by multiple people, like collection plates, communion trays, song books, bulletins. Really think through before your service is conducted how you can avoid the transmission of COVID via objects. And then posting signs at the door, just reminding people that if they are symptomatic, to not enter. Give them, the option of that virtual service. Having that symptom screening, as I mentioned before, at the entrance. If people are coughing, having tissues and sneezing, and really have your ushers just be on the lookout for people that may be symptomatic, and have a way for them to be separated in a very respectful but concerning way, because COVID is a very serious illness. And then it's really important for our faith communities to be engaged with us in combating misinformation. We got plenty of resources, as I said before, on the DHHS website, fact sheets, videos, other materials. We want to make sure that people get really good information. Also, if your facilities have been shut down for a while, it's important to recognize that water and ventilation systems can actually spread Legionella and other waterborne diseases. So the CDC has some guidance on how to actually reopen buildings in a safe way. And also, please remember that this is flu season. We're already seeing people, as normal, get hospitalized as a result of the flu. Flu is a big killer every year. And flu in combination with COVID is really deadly. And one of the things we're finding is that our hospital emergency rooms, our inpatient beds, as well as our ICUs, are really starting to increase. So please, as much as you can, encourage folks to get the flu and have a buddy system or some way that the church can be involved in helping people get to places where they can receive the flu shot or facilitating it for them. So as I mentioned, we've got a lot of other resources that are available on our website around prevention. We've just put up some guidance on private social gatherings and Thanksgiving, even Black Friday. And so prevention is a real key focus of ours. Testing is another one of our foci. We're really very engaged in making sure that there's testing available in communities that have a high population of people that are from historically marginalized populations, or frontline workers, or folks that may likely not have health insurance. So we've used a mapping system to be able to identify those communities, and we specifically put testing into those areas. We've got our CHAMP testing that we've undertaken, which really focuses on making sure that people get free testing It's in their communities, no documentation is required. And we're working with our community partners to get those testing sites publicized and really supporting them. And that's the other thing that churches can do, is actually help sponsor testing events in the community. So again, want to make sure that everyone has access to testing. We're even recognizing that there are a lot of people that aren't symptomatic. And so we're encouraging folks now, if you feel like you've been in contact with someone that has COVID, or if you're in a high-risk occupational setting or social setting, get a COVID test. Okay, and there's more and different types of tests, even the rapid tests that are coming out that should really, by the beginning of the year, make testing much more convenient, results more quick, and be dispersed more throughout the community. I talked about the CHAMP testing. The other thing that is really important is, once you get tested, if you're determined to be positive, to really work with the health department. A contact tracer or a case investigator may call you. Pick up the phone and be really clear on who you've been in contact with, so that that individual can get tested and we can make sure that we're controlling the spread of the virus. We also developed this Slow COVID NC app that's in the Apple Store or the Android store, where you can download it, and it will actually tell you if you've been in contact with somebody that has had COVID, if they also have that app. It's anonymous, so your information is not collected or shared. It really is just a tool for you to be able to help protect yourself. We've also developed some isolation and quarantine support programs for people that may not have resources if they're asked by the health department to set out for 10 to 14 days from work. We want to make sure that they've got payments to be able to make rent, to be able to put food on their table, and to be able to have the healthcare services that they need. And we've also assured that there's a workforce available to increase case investigation and contact tracing, and that workforce is diverse, including African Americans, people from the Hispanic and the Latinx community that are culturally and linguistically competent to be able to provide these services. I talked about that Slow COVID app. You can download that on the Apple Store. I mentioned the fact that we do have programs available in essentially 29 counties for people that have been asked to isolate or quarantine. We actually even have some additional services in up to 50 counties for people that need support with income assistance because they don't have sick pay, they don't have the resources necessary to isolate or quarantine. And we're utilizing community health workers to actually deliver those services. And then our fifth work stream is around behavioral health. We know that COVID is creating a considerable amount of stress in the community, and we've developed several initiatives, including our SCOOP Behavioral Health Initiative and our Hope for NC Behavioral Health Program to support people that are experiencing crises or depression, anxiety as a result of COVID-19. And then, as I said before, procurement. It's really important that we get resources and funding in the hands of community-based organizations that are doing the work on the ground. It's a real challenge for us. State government can be very cumbersome in terms of working through procurement approaches, contracts, and we're trying to learn from this process ways that we can be more accommodating, if you will, to smaller organizations that don't necessarily have the startup capital and the resources to prepare an application and get a program off the ground. We're also planning around COVID vaccination. We've been working with a wide array of partners across the state to develop our COVID vaccine distribution plan. It went into the federal government back on October 16th. We got a reply back, so we're working on a second version of it. The flu vaccine really is going to be the best way that we can prevent the spread of the virus. We can actually get past COVID-19. And what we know is that we're at really an epicenter in North Carolina with Research Triangle Park and other areas that have our academic institutions as well as our pharmaceutical partners developing the vaccine. We've got several promising trials that are underway, as I said before, happening in North Carolina, and we're really recruiting volunteers to participate. These are, as vaccine trials go, these are being developed in the same way, a 3-phase approach, starting with a small phase first that has like 20 to 100 volunteers to determine if the vaccine candidate is safe and what the appropriate dose is. And then the second phase really looks at whether it has an immune response and that it's safe, increasing that number of volunteers in the trial to several hundred. And then that phase 3 really looks at the safety and the efficacy. Does it actually prevent COVID-19? And that takes thousands of volunteers, and it takes a wide variety of volunteers from different groups. That's why we're really encouraging people from HMPs to participate in these trials. We expect that there will be, we've gotten really good news from Pfizer in terms of one of their vaccines that seems to be very effective at preventing COVID. We're still waiting for that trial to complete. There's not being shortcuts taken. What's happening is you got entities that are working collectively and utilizing multiple strategies at the same time, but still following that standard protocol for safety, and making sure we've got a manufacturing process that's taking place at the same time as the vaccine is being produced, so that once the vaccine is deemed to be safe, there's supply that can go out to states, down to municipalities, to healthcare providers to get folks vaccinated. Our North Carolina Institute of Medicine has really been working with us to make sure we're leading with equity on our approach to the vaccine distribution, and making sure that people that are impacted the most have access to the vaccine earlier. And so they have drawn up a plan around the distribution of the vaccine, and really prioritized in 3 phases. And the prioritized groups are healthcare workers at high risk of exposure, because if our healthcare workers get sick, then who's going to take care of everybody else who's sick? And then long-term care staff and residents, because they were disproportionately impacted by COVID early on due to their fragile health status. And then people with 2 or more chronic conditions. And then looking at also people in high exposure settings, congregate living settings, and frontline workers. So again, really making sure that people that have been impacted have access to that vaccine. And so our commitment really is around trust, making sure people understand the benefits and the risks, that they make informed decisions, and they know how to get the vaccine. So in terms of going forward, we know there's going to be a lot of challenges with controlling community transmission. That's happening right now. Pandemic fatigue. People are just tired of dealing with COVID, tired of wearing face coverings, tired of social distancing. They want to have Thanksgiving and Christmas like it always has been. They want to go shopping. They want to go to movies. But we still have a lot of work to do to get this pandemic under control. And as I said before, it's spiking. We also know that we're in a state where we're bordered by other states. And when those states have spikes and people come into North Carolina, that passes the virus over to us. We talked about behavioral health challenges with depression and substance abuse, also interpersonal violence. And one of the things we're also seeing is just how COVID has impacted the economy: job loss, home loss, wealth and asset loss, damage to people's credits. And also we've seen social upheaval. And we know that we've got big issues on our plate going forward, such as climate change and other needs that are really going to be pressing up against our ability to recover from this pandemic. So here's just a brief summary of the things that we're doing at DHHS. What we really need you to help us with is going to our website, being familiar with particularly the guidance on faith-based organizations, religious services, holidays, making sure that people get tested, hosting testing, practicing the 3 Ws, making sure that folks stay home if they're sick, and really supporting the work of community in assisting one another, making it through this pandemic. I really want to thank you for the opportunity to give you this very brief overview of the work we're doing at DHHS. I look forward to our discussion this evening and responding to your questions.
Thank you. We would like to thank Dr. Deputy Secretary Ben Money for being with us this evening. He is one of